Okay, let me begin by thanking the organizers for inviting me here today. It is very exciting to tell you about some of our work. And I'd like to, at the end of the talk, I'd like to talk about also what we plan to do in the future. This is my disclosure. It doesn't have anything relevant for what I will be talking about today. Can you guys see my pointer okay? Does that work? And is there anyone on Zoom, or like it's okay if I point here? Yeah? No one's saying no? Okay, good. All right, so let me start by introducing myself. I'm a pediatric critical care physician, so that means that I take care of children in the ICU, in the PICU, pediatric ICU. I also have research training in developmental biology. So actually, we study frogs, and that research interest was really inspired because so many of the children that I take care of in the ICU have congenital anomalies, birth defects of one kind or another, and so that has really inspired me to study developmental biology with, at the time, some hope that we could connect those two. And what's really exciting is in 2009, when I was at Yale, we developed exome sequencing. Well, the group developed exome sequencing, and we started applying genome sequencing, exome sequencing on children with congenital anomalies, and basically then used a patient-driven gene discovery approach to then go into animal models and study mechanisms. So that's actually what I do. And just recently, after 20 years at Yale, I moved to Cedars-Sinai, where we're building a large genomics program, which is what I'll talk about today. Okay, so a quick outline of our talk. I'll review genetics and genomics, high school to med school. I'll talk about the impact of congenital anomalies. I think many of us don't actually recognize that how big a problem this is. And then talk about the technological revolution in human genomics. It is extraordinary, and I think there are some graphs that describe this that are just staggering. And then, as we are a medical community, let's go cases. And I hope these cases were extremely informative to me as we started developing them, and I hope they will also be informative to you to sort of understand the impact that genomic sequencing can have on children. And then finally, our last thing, our vision of genomics in medicine. Okay, so the central dogma. So just as a reminder, DNA is the instruction book that determines how our cells will operate. That is transcribed into RNA, which this RNA is then translated into protein. That leads to biological function. In my case, healthy embryonic development, and therefore you get beautiful, healthy babies, generation after generation, right? And this is the real goal. Okay, so what is the problem is that you can have mutations that occur in DNA, and those mutations then lead to a change in the RNA, which is a change in the protein, which then leads to biological dysfunction. And this is the problem, because this biological dysfunction during embryonic development leads to a congenital anomaly, and that leads to disease and phenotype. And a patient then, here's a little baby here who has congenital heart disease, and you can see that to where, have the baby on a ventilator, multiple pumps, sending inotropes into the child after it's had multiple major congenital heart surgery in order to reconstruct the baby's heart so it's something that could be survivable. And so one of the challenges for me as an intensivist in this situation is that I'm always faced with a mother asking me, why did this happen to my child? And then the follow-up question is, will this happen to my next child? And for the longest time, there was no way for me to answer that. We would shrug our shoulders, and it was extremely unsatisfying. But all of that has changed now, and that's what I want to tell you about today. Okay, so let's step one step back. Let's talk about the impact of rare diseases and congenital anomalies. So today, congenital anomalies or birth defects are the #1 cause of infant mortality in the US and Europe. Not prematurity, not cancer. Children are dying because of congenital anomalies. And that in many ways is because we have been so successful at infectious disease prevention. We can sort of group congenital anomalies into these categories of rare disorders, disorders that are caused by genetics. And one of the things we should understand is there is a very unsatisfying diagnosis that we make frequently, which is that this sort of descriptive diagnosis, this idea that this patient is having seizures, or the diagnosis is tetralogy of Fallot, a form of congenital heart disease, or cancer. But those diagnoses don't really address what's really wrong. They're a descriptive, they're a very fancy description of the phenotype, potentially billable, but not very helpful in trying to understand what's going wrong. And many of these disorders have a genetic basis, and so what we would like to do is identify the mutation in the gene, make a molecular basis of disease, right? Understand the molecular basis. And without that molecular understanding, there are just so many unknowns. I mentioned some of them. What is the cause? What is the prognosis? What is the likelihood that the next child will be effective, and can we tailor therapy specifically for that molecular diagnosis? And again, as I mentioned earlier, this is the #1 cause of infant mortality. If you combine all these rare genetic disorders, this is a major cause of childhood illness. And so this is something we must address. So again, I mentioned to you earlier, families would ask me, why did this happen? Will this happen to my next child? And we used to have, really no answers to that question. And now everything has really changed. And the reason it has changed is because of this graph. So the initial human genome cost $3 billion. So this is the cost of the human genome over time. And you can see it starts at, a lot. $100 billion, is that $100 billion? Yeah, $100 billion, right, back in 2001. And today, you see the graph ends at 2025. So when we started 2008, 2009, a whole genome was $100,000. An exome was more like $2,000 or $3,000. And today, a whole genome is $300. That's the price. In fact, actually, many of the sequencing centers don't like me to tell what the price is because tomorrow it'll be lower, right? And this is incredible. And as a consequence now, genome sequencing, all of us can get it, right? It is that inexpensive. Now, there are many technical aspects to this cost that I have not included. For example, this is just the cost of sequencing, right? There is a cost to, for example, whether you're going to do whole genome or exome. There's costs for the computational alignment, storage, short read. I haven't really included any of that, but understand that the costs have plummeted in a way that is really unprecedented. If only our phone bills would plummet this quickly, right? It's really extraordinary. And that has enabled many ways to identify genetic disorders. So this is the way we used to do genetic disorders, okay? So this is hemophilia in the royal houses of Europe. This is a perfect genetic project. The family has a lot of money. They can fund the work that you do, and you have lots of patients for which you could do sequencing. And in 10 to 15 years, they identified the gene that caused hemophilia. Today, I just need a trio, parents and a child, and I can figure this out in a week, right? This would have taken a couple of days if I pushed it 3 or 4 days. That's the power now, right? What used to take a decade to solve can take a week now. All right, so let's go through some of these cases, and I'm happy to take questions as we go along. Please feel free to ask. Okay, case number 1, diagnosis, not seizures. So a colleague of mine had a friend, he was a nurse, that came to him and said, I had another seizure. She's a 50-year-old female with history of infrequent events beginning in her 20s, where she would pass out with total body shaking, no precipitating factors. She had a negative EEG. Of course, she didn't have an episode during the EEG. And she's been on anti-epileptics, but not currently. She also had a cardiology evaluation, which was very appropriate, and it had a normal EKG with a QT of less than 460 milliseconds. My colleague asked her, does anybody else in the family have seizures or similar events? And she said, well, my mother. Her mother is a 72-year-old female with history of seizures and had been in the ED 2 years earlier. So when she was 70, she was in the ED. They did a trace. That's terrifying. As a critical care physician, this creates panic, right? She had torsade de Pont. QTC was 580 on EKG, and she was diagnosed with long QT syndrome. So we can draw a family tree. And in fact, this was stunning to us, right? Because there were actually 2 family members. Okay, so here's our patient. with syncope and normal QT on EKG. A sister who had, as an elder adult, had atrial dysrhythmia. Mom of the patient who had syncope torsades. And then mom had two older sisters who had died in their 30s, right? Truly a terrifying pedigree. And so the question is, what's going on here? And so we approach this to do sequencing. This used to be an old slide. Insurance is usually not a problem anymore. And this is what we found. So I'd like to review here how we do our genomic analysis so you get some sense of what we find. Okay, so what we discovered is that if you look at a table like this, many genomic sequencing results will give you data like this. This is the position, so on chromosome 7 at position, that long number, because there's a lot of base pairs in your genome, there's an A to G change. This is the variant. It's in a gene called KCNH2, which is a potassium channel, ERG class family, and the variant changes a C at position 555 to R. What we do know is that if you look at the allele frequency, how frequently we find this in the population? 0. It is truly novel. Never has it been seen in the population. This is an old slide. Now we no longer use exact anymore. We use Nomad. It has millions of genomes in the database. And so that's important because we're expecting a rare variant. If this was common, then we probably would ignore it because that would suggest many people have this variant and therefore not everyone is passing out and having these arrhythmias. We can see that the proband has the variant as well as mom, and her sister does not, right? And so that's all very reassuring. But there's another variant in this family, which is KCNQ1. Again, on chromosome 11, it's also a potassium channel, and there's this R293C variant, which has also been described previously. This is a novel variant, so it has not been described previously, but this is a known variant, and it's been described as pathogenic, and we'll talk about what VUS means in a minute. It is also extremely rare. 1 to 10 to the negative 5 is the frequency in the population. And again, here, interestingly, our patient does not carry the variant, but mom does. Okay, so let's see how that looks like, okay? So just to remember, just very quickly, so genetics of long QT syndrome. As we remember from our EKGs, there's a number of ion channels that are important for the different aspects of depolarization of the atrium, the ventricles, and repolarization. All of this is driven by different ion channels. And KCNQ1 and KCNH2 are both known genes that have been described to cause long QT syndrome, 2 different types, and together, variants in these genes represent 60-70% of all known long QT syndrome. So we're finding variants in genes that make sense. Okay, but what I'd like to tell you now is that the genome is complicated, right? And interpretation of these variants can be a challenge. So we actually classify genes as sort of 2 kinds of categories. One is genes that have clinical relevance, or clinical genes. These are genes that are known to cause disease. So KCNH2, KCNQ1, these are known to cause long QT. CFTR causes cystic fibrosis. Hemoglobin causes sickle cell disease. And in fact, there's some very useful resources that annotate all these genes and give you some very useful information of the genetic disorders. So those are the clinical genes. But then there's also genes of unknown significance. These are genes that have no association with human disease. So there's 20,000 genes in the human genome. Only 7,000 are known to be disease-causing, right? And so you could say, well, Mustafa, you've had millions of dollars worth of NIH funding. What the heck are you doing? Why is it only 7,000? And we're working on it. But there's a lot still to do. So 2/3 of all our genes are still genes of unknown significance, which we see as an exciting opportunity for discovery. This is the research that we do. And there are thousands of scientists, geneticists, clinicians trying to convert genes of unknown significance to clinically relevant, right? They're trying to discover the genes. And so again, in this case presented, both KCNH2 and KCNQ1 are clinically relevant genes. They're not genes of unknown significance. But the genome is complicated. Even with known disease genes, right, like those 2 potassium channels I mentioned, what does a given variant mean? So we can also classify variants. There are pathogenic variants, sequence changes that cause disease. We know of these. For cystic fibrosis, there's a known deletion that causes cystic fibrosis, and we know that that is pathogenic. Then there's a category that's called likely pathogenic. These are sequence changes that are suspected to cause disease, and offline we could talk about how they suspect that. And then there's variants that are benign, variants that we know really have no effect on protein function, no effect on disease. But if you don't fall into one of these classes, you fall into the category of variant of unknown significance. And these two variants, KCNH2C55R and KCNQ1R293C, which we found in this family, are both variants of unknown significance. Are they benign? Are they pathogenic? We don't know, right? We just don't know. And so these are variants that don't fit into the above categories of pathogenic, likely pathogenic, and benign. So how do we begin to analyze it? Okay, so one thing we can do is take advantage of evolution. So KCN or other species. So KCNQ1, if you look at the other species that have the KCNQ1 gene, you can see it's found in humans, chimps, cows, mammals, chickens, frogs, fish, and even worms. And you can see here this is a schematic of the protein. You can see each of these barrels are the transmembrane domains of this ion channel. And so these are sort of a schematic. So this is the protein that before that goes transmembrane, then it goes outside, then it goes transmembrane inside, and so on. So that's what this describes. And you can see this R293C mutation is on the outside of on the extracellular portion of this protein. And actually, if you look at it, this arginine here is not even very conserved amongst mammals. In fact, there is some possibility that you could put a Q there, and the protein seems to be perfectly fine because presumably these cows and dogs are not having arrhythmias and things like that. So that made us wonder, is this really a problem? On the other hand, with KCNH2, you can see the mutation is in the transmembrane domain, and this region is extremely well conserved, even down to fish. Identical amino acids, and so that suggests to us this C to R change may be really detrimental to function. The important point is it suggests. So we did experiments, right? Okay, so this is ion channel electrophysiology. I won't go into it. Fortunately, it's very easy to interpret. So this is patch channel clamping of wild-type KCNH2, and you can see at different voltages, there's currents that are created by this ion channel. What's very nice for us, anyway, is that when you make this variant change in this ion channel, no current, right? Clearly, this variant of this channel completely eliminates function. Okay, so we could say that this is now detrimental to function. If we do the same experiment with the KCNQ1, here's wild-type KCNQ1, has beautiful currents at different clamps. On the other hand, with the KCNQ1 arginine 293 cis variant that we found in our patient, I mean, these look identical, right? There's no change in function, and our experimental data shows that KCNQ1 R293C variant does not impact function of protein. Okay? So what does this mean? So again, here's our family tree. This our patient has a KCNH2C55R variant, which we know completely knocks out this protein. The mother of her has KCNH2C55R, but also KCNQ1R293C, which is actually irrelevant. And now that's interesting because the other thing that we found in her genome is that she actually has a second KCNH2 variant, which is actually a little more frequent and is thought to have a moderate decrease in function, which is not necessarily disease-causing if you have a healthy allele. But there's actually good data now showing that if you have a variant that doesn't work along with this variant, it leads to severe disease. And actually, our patient does not have this variant, right? So what we can immediately discover from these patients here is that these two people have different diseases based on their genetics, and therefore they need different therapies. Mom got a defibrillator, right? Because she's at so high risk, and it explains why she has this prolonged QT and torsades. Well, on the other hand, our patient just started on propranolol and had complete resolution of symptoms. Right? Now, the other thing that's very important with genetics is not only does it teach you about the patients that you're studying, but it also has implications for other family members. Mom has had 2 sons, right? So we sequenced them as well, and we found that her one son has a KCNH2 variant. He's had no symptoms, but was started on propranolol, anticipating that he might develop symptoms, which, as you can see, can be sudden death, right? And so the risk of starting propranolol seemed relatively mild compared to the potential outcome. On the other hand, her other son has no variants, perfectly healthy. He requires no therapy. Again, with the genetics, we can precisely begin to predict what could happen next and start precisely treating these patients. These actually, you can't even call them patients. They're healthy at the time. But we can start making predictions as to their risk based on the genetics that we see. And that's what's really powerful here. And this was super exciting. So what are the take-home messages? First, our patient was misdiagnosed with seizures because the EKG was negative. Genome sequencing identified KCNH2 mutation and really suggested that intermittent arrhythmias. Mom's EKG with Torsades certainly helped as well, but it suggested that this is what the pathology might be. Started on propranolol with resolution of symptoms, far more effective than the anti-epileptics that she was on. Patient's mom has a different disease. She has 2 KCNH mutations, a more severe form of the disease, and actually has prolonged QT and needs a defibrillator, which is different than her daughter. Her son has no symptoms, but at risk for sudden death based on this shared KCNH2 mutation. And so that means that sequencing one family member can inform others. And we can avoid symptoms by early genetic diagnosis. And this was very exciting to us, as an opportunity. Finally, the genome is complicated. We need to do experimental testing of variants to figure out if they're important or not. There are genes of unknown significance and variants of unknown significance as well. Okay? Yeah, you have a question?
Interesting, but how often do these patients, let's say the 50-year-old female misdiagnosed, comes to neurology, goes to cardiology, goes to the emergency room, gets treated, misdiagnosed or undiagnosed, how often do these patients in real practical medicine go for genetic testing?
What I will argue is they should always go for genetic testing. We'll come to that in a minute. Thank you. So the question is, how often do they go for genetic testing? And I think the problem is not enough. Okay. Case 2, diagnosis and then a healthy baby. Okay, so here, a family presents with 2 early-term pregnancy losses. In the next pregnancy, there's a little bit of polyhydramnios at 35 weeks. A baby girl is born at term at C-section because of this polyhydramnios. And in the delivery room has severe hypoxia, is immediately intubated and ventilated. They do 1-hour resuscitation in the delivery room. They're simply unable to oxygenate and the baby died. At autopsy, it was completely unremarkable except for severely hypoplastic lungs. The normal weight of a newborn's lung is 53 grams. This baby's lung was only 14 grams. And again, no etiology identified. Family proceeded to conceive again, this time having a healthy baby girl, alhamdulillah. A third pregnancy then went to term as smooth as the second. They did a planned C-section again, and again had a baby boy with severe hypoxia, intubated, ventilated, unable to be resuscitated, and died after 90 minutes. Autopsy again showed severe pulmonary hypoplasia, but otherwise a normal infant. This is the x-ray. You can see the baby's intubated. There's just no lung volumes. Actually, you can see the abdominal organs are almost all the way up in the chest. Here's the autopsy. Here's the heart. You can see the lung, which should really fill this whole cavity, is just extremely tiny. As an intensivist, I have to point out that the blood gas was terrible, lactate was sky high. And we can see that we have this family, mother and father, 2 lost pregnancies, patient, brother, and then this one healthy sister. And so they came to us asking, what is happening? We did genetic analysis of the whole family, and we found variants in AARS2, which I'll tell you in a bit. We found a arginine to tryptophan variant, as well as a frame shift, right? So frame shifts are very severe. They completely abrogate protein, so that would be likely pathogenic. Mean allele frequency for both of these alleles were very rare, and you could see, well, let me just go to the tree. You could see that mom carries one variant, dad carries the other variant. This is what we would consider, so the patient is compound heterozygous, has gotten a deleterious variant from father, deleterious variant from mom. Patient and brother, who both passed away with this severe lung disease, have both all those variants, while sister only carries one. And so this seemed like a very good candidate gene to cause this disease. So what do we know about this ARS2? It's a mitochondrial aminoacyl tRNA synthetase. Right? This is one of the things that happens when you do this, is you start studying biology that you never would have studied before. And so in the mitochondria, there's a genome, and there's tRNAs in the mitochondria that are necessary for protein synthesis. These gene variants can lead to mitochondrial disease, primarily affecting the brain, skeletal muscle, heart, and kidneys. But what about isolated pulmonary hypertension? None of this that's been described before looks like pulmonary hypertension. There are previously reported patients with secondary pulmonary hypoplasia due to cardiomegaly, and there was actually one previous patient with the exact variants that we identified in this family that died at 3 months of age from cardiomyopathy without pulmonary hypoplasia. Now there's another gene, RARS2, not to be confused with AARS2, which is actually a very similar protein. It does very similar thing, and those two siblings had primary pulmonary hypertension. So we were excited as an opportunity, but really ARS2 was a gene of unknown significance, and this is really becoming a research study, and we're studying what the function of this protein is. We think we may have made a new association between ARS2 and pulmonary hypoplasia, but we should recognize that research could be wrong, right? It is research. We communicated these findings to the family with caution and respect, told them, look, this is an interesting candidate, we're excited about it, and the family decided that they wanted to have another child. But they also immediately recognized that if we are right, then they have a 1 in 4 chance of another horrible outcome. So they took this information, went to their OB/MFM folks, and they happen to be in Australia, where it has a very different healthcare system than ours, and they decided to do IVF. They were going to do IVF, sequence the embryos, and select embryos without ARS2 mutations, implant those, and let those go to term. This led to panic on our side. We think ARS2 is causing the disease, but we didn't know for sure, right? And so we told the family, whoa, wait a minute. What if we're wrong? And they were said, this is the best information we have. We're going to have another child. We would like to use this information for this informed pregnancy. And I'm happy to say that this is big sister and a new baby, healthy baby, right? Really exciting. Just knowledge allows for an intervention. So I think here the take-home message is that knowledge is power, but particularly molecular knowledge. This is a very different set of lessons I'd like to say. First, families are grateful even for research results. You got to understand, this is not research that we're doing on a population of people. This is really specific to this family, right? This research is directly relevant to this family. So by telling them the results of this research, we actually really inform to this family what we think might be going on. And that's exciting because it gives them information. It gives them a return from research that's very different than what the standard model is. The standard model is you study 200 patients, you make a discovery, you publish your paper in New England Journal, and then months later after you found a drug or whatever, you can have an impact on the family. This can be immediate by just giving them information. And so it's very important for us that we think of these families as participants in research, partners in research, and not just subjects, right? A very different view of the way we think about clinical research. The second thing is risks of recurrence is predictable. Recessive variants have a 1 in 4 chance, but if it was a de novo variant, right, a variant that just happened in the germline, happened in the sperm or egg, the risk of having another patient like that would be nearly 0. That's very, very big difference, right? And of course, we can figure that. We sequence the parents, we don't find any variants. We sequence the child, we find a variant, we know it's a de novo. We can let the family know that your risk of recurrence is basically 0. Incredibly reassuring. And then the other thing that it taught me is that pre-implantation genomics can prevent genetic disease. And you know, as a pediatrician, prevention is what we do best. Of course, that does require that we sequence prospective parents, and we have that sequence data available for everyone. Okay, good, we're on time. All right, so let me tell you this last case. This is a very interesting case for us because we actually have some opinion from the family. Okay, a mother's voice and the impact on her family. So again, here's our family tree. We have our young boy who died at 18 months from severe lung disease of uncertain cause, right? We had just had lung disease, no idea. At 18 months, this little boy died. Turns out he had an older sister who died from similarly mysterious lung disease at 26 months. No idea why. They have an older brother who's 9 years old and very well. And at the death of this child, mom was 9 months pregnant, otherwise well to date. So just imagine what must be going through her mind, right? She's just lost 2 children at about 2 years of age, has 1 healthy son. All she can think about is this child going to fall in this category or in this category? Absolute terror. In fact, after the first child died, mom asked, parents were told that they would never have another child with the same terrible disease until they did. And now they have a 3rd child, right? Just about to be born. And waiting for a year, 2 years, what will happen? Of course, we do sequencing. We found a number of different variants. I won't go through the details here. If you look at the genetics, the key candidate is this gene called NARFL, which is a nuclear prelamin A recognition factor. You can see we have a frame shift mutation, or a stop codon mutation, and a variant that are, again, very rare. If we look at the family tree, you can see, again, mom carries 1 copy, dad carries the other copy. Both children that passed away carry both bad copies. The 9-year-old son only carries 1 copy, 1 bad copy, and of course we have no idea with the unborn child. Now, one of the things that's important is, as a scientist, we look at these kinds of trees all the time. They're circles and squares, but we should remember there are names, there are people associated with this, right? That these are a family of people. And one of the exciting things here for you today is that, you know, Kendra Hafley, who's the mother of all these children, I was invited to the NIH to give a talk, and the nature of the talk is called Voice of a Patient. So the NICHD also asked me to bring a patient along, and I asked Kendra if she would come and tell her story to the whole world, basically. And so what I'm about to show you is actually a video of some of that talk, which is unique in the sense that I can actually present it to you, right? She said it publicly. But it is not unique in the context of the experience that she's had, right? And so I think there are many people here who could relate to her story. And there's a few points that I'd like you to listen for. One, the diagnostic odyssey. She'll tell you about multiple tests, multiple referrals, multiple hospitals, no answers, right? And I think if we had done the genome sequencing at the start, we could have helped there. The severity of the illness only leads to more desperation and isolation. You know, mom is an expert. When you've been at Yale for 20 years, you get special training in arrogance, and you just assume that patients can't understand complex genomics. And what I'd like to show you is that is not true. Mom is I think she's like a health instructor, like a fitness instructor, aerobics instructor. But she can manage a high-frequency oscillatory ventilator and arterial blood gases better than most of my residents. Guilt. Am I failing as a mother? Right? Extremely powerful. And we as clinicians, here's this child that's coming into the ICU with lung failure, and I have no idea why. I cannot explain this. I am completely wondering if I'm incompetent. Because all the management systems that I try, I can't explain why this child continues to get worse. Okay, so please listen to this story. Let's see if I just click.
My name is Kendra Hafley, and I'm just one of many faces of rare diseases. I kept begging for anyone to do something, find out what is wrong with my daughter. The next morning, I had no idea. As I was kissing her and telling her I loved her and that she was going to be okay, that it was going to be the last time that I would hold my daughter alive, I never would have let her go. Isabel did have pulmonary hypertension, but it was due to her incredibly sick lungs. Lungs so sick that they were struggling to inflate and oxygenate. He told me he believed Isabel would require a lung transplant and that we needed to consider getting her into a transplant center. Our doctors worked to get us accepted into a transplant facility, and we waited on Isabel to tell us when she was ready to come off ECMO. After 21 days, she was ready, and she did great on the conventional vent. We got accepted to Texas Children's. We felt optimistic and hopeful new lungs were just weeks away, and Isabel would be able to breathe freely once again. Transport was smooth. Isabel was showing beautiful blood gases, and we were able to grab Damon, my husband, who had traveled commercial from the hospital lobby to join us as we entered the hospital. Within minutes, Texas Children's was working to transfer Isabel to their machines, and for some reason, they decided to handbag her instead of transferring her directly to the same vent settings as in Omaha. The 275-pound male nurse, not knowing Isabel, saw her Brady due to a vagal response, and he jumped on her to perform CPR. Isabel's aorta was torn. I immediately went out of body, and after 30 minutes, our nurse Angel touched my arm and told me I could still hold her while she was warm, and I could ask them to stop at any time. I asked the doctor in charge how long it had been, and then I asked them to stop. And then I asked them to leave the room so that my nurses could help me clean up my daughter. That night, my daughter became a star amongst the heavens. She was 2 years, 2 months, 2 days. Through meeting with our doctors, we were assured we could have 100,000 more kids and would never have a sick child again. This wasn't genetic. This was just a fluke in nature. Sweet Silas arrived and loved cuddles, which were therapeutic and welcomed. He reminded us of his sweet sister at times. He was also silly and loved dragons and books. The days were filled with hope, and it felt like we were healing. After his first bout with hypoxia, during an illness, I requested a consult at Colorado Children's to meet with one of the world's leading specialists in children's interstitial lung disease. We had an appointment scheduled less than a month away. Silas caught RSV, and we drove immediately to Children's, where he was stayed for the next 14 days before convincing them to let us leave on oxygen to head to Colorado. It couldn't be a coincidence. This was too similar to Isabel, and happening just months apart from her first illness. Silas had pulmonary hypertension. We decided to attempt a different way of ventilating, and the moment BiPAP was attempted, Silas turned gray and his eyes rolled into the back of his head. My sister was with me when Silas coded. Soon my whole family was there. Damon was immediately on a flight home, and once again the nightmare began, only this time I was 8 months pregnant. I worked daily on PT with Silas while we searched and researched, and although we had an incredible team of doctors working with us, no one had ever seen anything like our kids. We were once again alone on this unknown island. Some doctors gave up hope. You could see the pity on some of their faces. I told the doctors I was going to be headed to Lincoln to have a baby, and it was arranged so that I could watch through a video monitor my sweet baby boy while I brought his brother into the world. I arrived at the hospital at 5 and delivered Stone at 9 via C-section. Things weren't going well. I called my ped and my midwife, and both told me I could leave. They would give me meds and get me out of there. By 5 p.m. that evening, I was back in Omaha. Less than 19 hours from having surgery, I was bringing my son to meet his brother, the first and last time. I was exhausted and destroyed and so tired and so happy and so sad. Roman and Silas made hand molds, and we all read books. When we were ready to let him gracefully and peacefully pass, Roman held him first. They laid together for hours and Roman slept, one last time holding his baby brother, his best friend. Then it was time for Dad. They laid and snuggled, and I knew he needed to hold him as he passed. So I just loved on Silas and Stone and Roman and Damon as we waited until he took his final breath and his heart had its final beat. He was 19 months old. One of our intensivists with a passion for research stopped us and asked if we would sign papers to send our genetics to Yale. I said, absolutely, and we all signed. He promised no matter what, we would hear the results. Yale would share any results with us. The next year was a blur. It was painful and joyous, wondering how long we had with our new baby and worried our oldest would someday fall ill. And then we got a call. Yale had found something. Did I want to know? Yes, now. My husband and I both carry different mutations on the same gene. Isabel and Silas received both. Roman carries mine. Stone carries neither. Did we want a video conference and hear from the research team? That was possible? Yes. Please, answers. Tell me everything. A video conference was scheduled, and all at once, I wasn't alone. I found someone who cared as much as I did about finding an answer as to why my children got sick, why they died. But what's more is they want to understand their disease process. They want to know more. They want to know if there is a treatment. So do I. They want to know, and they will, and they became our beacon of hope. This news was life-changing. After so many years of trauma and tragedy, we could finally actually breathe, the thing we so desperately wanted for our babies.
So obviously that's a powerful video, and I think it shows you the power of this molecular diagnosis. I think families are desperate for answers, and that drives me to try to figure out what's going on here. And so, I want to now, I'm running a little late, so I want to get to our vision of the future. So, our goal is really to integrate genomics into everyday pediatric care to improve the health and well-being of all children. The idea is that if you have genomic health, you have child health, and that child health is entirely dependent on genomic health. And the vision we have and the goal that we're working towards is basically all newborn children will have whole genome sequencing done. It will be basically part of their newborn screening. And then we can divide children into different categories. For example, for those that have disease genes where we understand, right, not genes of unknown significance, clinically relevant genes, we can make those clinical diagnoses very rapidly, right? No diagnostic odyssey. Make the diagnosis quickly, and we know that early treatment makes a huge difference. So for example, if you look at children with cystic fibrosis, the sooner you implement therapy, there is good data to show that their IQ points are better, right? Sooner is better. And of course, we could then do genetic counseling. In those children that are symptomatic but without a clinical diagnosis, this is an opportunity for discovery, right? We can immediately have their genome in hand. We can then do gene discovery, and actually in examples that I don't have time to talk about, we've actually, when you discover genes, there's also an opportunity for discovery of drugs that can affect those genes. And so there's an opportunity for returning research results and using those research results to inform us. But now you might say, well, we're going to sequence all those genomes. These two categories are actually a small percentage of all children, right? What about all those other children that don't have a clinical diagnosis or have symptoms? They're basically healthy children. And I would say that, in fact, there's a lot of value to sequencing them as well, because at some point in time, they will interact with the healthcare system, and we can now take advantage of pharmacogenomics, right? We could see different children metabolize drugs differently, and by knowing the pharmacogenomics, we could actually deliver drugs appropriate to them, right? In the ICU, we do this all this time with this beta blocker strategy where we give this tiny test dose because we're afraid if we give a bigger dose, their hearts might stop. So, if we knew pharmacogenomics, maybe we wouldn't have to do that again, right? And other drugs might be much safer. There's a lot of drugs for which we measure levels for where pharmacogenomics could be important. And then the other is lifespan genomics. In fact, this is one of the things that's very exciting. I'm running short on time, so I'm going to skip this real quickly. Again, children with known genetic diagnosis, we could diagnose at birth. If we sequence parents, we could identify carriers, prevent genetic disease. For those symptomatic children without a known genetic diagnosis, again, these are novel genes, genes of unknown significance. We can return those research results. And for all children, including the asymptomatic healthy children, but also these, we can take advantage of pharmacogenomics and identify genetic risks for adult disease, right? This is what we're calling lifespan genomics, with the opportunity that diseases in this stage of life are actually started in earlier lifespan, and if we could identify those variants, we could potentially intervene early, right? So for example, you can imagine Munir Ben is going to talk about cancer tomorrow. If we could identify those variants early, we could screen earlier, right? Screen more frequently, identify those patients that are at risk, and see if we could then intervene. In fact, other early recognition, we know there are genetic variants that predispose children to learning disabilities. Again, we could then, intervene early and for these at-risk kids. So that's our view, is that we do newborn sequencing, whole genome sequencing for all newborns. We're actually working towards that. We've a staged approach. We're going to start with the PICU, then the NICU, inpatient, and then move to newborns. It's a really exciting time. So, of course, this is not done by me alone. There's a team, the Yale team, and all of the people that did some of the research there. We're always grateful for our funding, our team at Cedars. I just want to make one call out to Safety Clinic. The Safety Clinic has been run by Sheikh Mufaddal Bhai. We have had 1 million patients visits over 16 years of Khidmat. I keep telling him he has to do this in logarithmic numbers now, right? If people were interested in participating, he has a poster outside. I encourage you to go check it out. Please, I can take questions. I'm sorry I'm running a little bit late. Please.
So, you probably are. Shukran. I'm sure you're aware, through SBMA, we run this Mu'minin SOS, second opinion service. Almost every doctor here also runs like a WhatsApp service as well, right? All these people are texting us, calling us, like, what to do now. How can we access this kind of technology, this medicine, not just through you, but are there centers of excellence here in US or in India or elsewhere, or what is even the intake process for something like this? How do we figure out who to refer, whom to refer to?
Yeah. So the question is, how do you get into this process if you have a diagnostic dilemma of some sort? And it is a real challenge because it is not uniform, right? It is, there are centers, children's hospitals that do this, even fantastic children's hospitals that actually don't deliver this kind of service despite having the high, the prestige related to that. I have to say that, this is one of the challenges of a technology in transition. We're still developing this, and there are genetic centers, but many of the cases that I would suggest, they're not looking at this yet. And so, I think we're sort of stuck with the situation that email me, and I will connect you with people. I wish I knew more people in India that did this, but certainly in the States, I know a number of community members that I can connect you. But this is a challenge, actually. Yes, please.
Is there a problem in terms of coverage, insurance coverage?
Yeah. So the question is insurance coverage. So insurance coverage is a bit of an issue. One of the things that's nice is that in the hospital, at least, it's all bundled care. So we're just, charging the hospital basically. So we've been able to deal with that. Outpatient, it does require insurance coverage. However, we've been finding that insurance is covering more and more. Medi-Cal covers it now. We've been showing very clearly that the diagnostic gain from genome sequencing is actually much better than an MRI. And so if you're going to do an MRI and pay for that, you should definitely pay for gene sequencing. And there's different strategies people have used to get the genomes sequenced.
Salam. My name is Lulua, Dr. Lulua Baranwala. I've been getting a lot of patients who are getting the CBR test kit, which seems to include pharmacogenomics and even genetic testing, and they don't have a consult with the doctor or anything. They just get this random report which says that something's positive. So one question is, how accurate is the CBR cheek swab? It seems to be run through reputable genetic labs, But two, is it also, can they test for adult onset diseases or only childhood onset diseases?
Yeah, so the question is, okay, so I think the question is, you know, there's these many groups will just do genetic testing and give you a report. And that report can have lots of different aspects to it, pharmacogenomics, all of this sort of thing. The concern I have is that one of the things that we're doing here is clinical testing. And in order for it to be clinical testing, it has to be collected in a way that samples can't get confused. So for example, you know, we always do trios, which is we do the parents and the child. And I can tell you a fair number of times, child is confused as parent and parent is confused as child, and the samples can get confused, right? And so it does require some caution, right? Because if you're looking at the parent sample and not the child sample, or, you know, especially in these sort of cheek swabs, send it off to get sequencing, I think I do have some concerns for that. And I think this is why 23andMe, for example, collapsed effectively in providing these kinds of, these sorts of tests. So I would urge a little bit of caution that samples don't get switched. Yes.
Excellent talk, first of all. Very, very interesting and very informative. And again, we can certainly see the value. I saw in one of the final slides, you kind of had a point there in passing about the moral ethical considerations. You didn't really touch upon that too much, but I think that's hugely important, probably
Yes.
a talk on its own, right? I guess my question is, you know, how do you, you know, kind of, you know, justify potentially, you know, if you, evaluate all genomics for all children, you know, creating some sort of stigma with children that are kind of growing up potentially thinking, I may have this genetic defect, you know, for the rest of my life. Do I have children? Do I not have children? You know, how do I look for a partner? How do I have this discussion with them? So on and so forth. Thank you.
So this is, you know, so I'm a so the question is, what about the ethics, right? Like, if you find that you have this variant and this now stays with you for the rest of your life, will this affect your ability to marry? Will this affect your, you know, what are the long-term applications? And there's lots of different conditions like that. For example, we know there are conditions where, you know, Huntington's disease, where you will effectively be mentally incompetent when you're in your 40s and 50s. Do you want to know that when you're 8 years old, right? So these are very important questions. And in fact, we're working very hard to develop panels. You know, one of the things for me is, I'm a critical care physician, so I want to eliminate diseases that kill children, right? So that is an easy ethical decision for me, but that doesn't solve the problem, right? And so what we're doing is working very hard to create different tiers. So for example, if we do newborn sequencing, there may be a set of genes that we will report at that time, and then another set of genes that will wait until the child becomes 18 and has an opportunity to reconsent, right? And at 18, they become adults and they can say, you know, I want to know whether I have a cancer risk or a cardiovascular risk or these other risks, right? And so we're working very hard to work actually with ethicists and actually community members in the community to develop partnerships to try to figure out what we do. And I think we as Mu'mineen should do that and decide how we want to do it. And I think this is the future. It is, 10 years from now, this will not be transitionary anymore. We should work on it now.
My name is
Thank you,
Umayma.
Dr. Mustafa. So, two comments.
Yes.
You gave a great introduction, saved me a lot of time from my talk tomorrow.
I'm
But
sorry I didn't have
for
time
those who want to know about the genetic testing, through the Amtullah Cancer Prevention Program, we have negotiated a whole genome sequencing for all 30,000 genes for Mu'mineen through the ACP project. The normal cost of this is 40,000 rupees. In India, we have been negotiating that for 8,500. The test can be done at your home or anywhere in the Emirates. The phlebotomist will go to your house, collect your sample, not asking for your ITS, not asking for your birth date. And I have talked extensively with Dr. Mustafa this week. It was very enjoyable because of our mutual interest. So what I would like to do, Dr. Mustafa, is contact this company, Newberg, because right now we are doing a panel of 225 cancer-related genes. I'm sure they have, if you have, the cystic fibrosis and all of these things, I'm sure they could narrow down a panel for childhood diseases, and we can negotiate even a better price than 8,500. And most importantly, this lab is willing to provide to me and to ACP the sequence of all the 30,000 genes, So in future, with Mullah's Irshad, we may be able to figure out whether the variants we are finding in our community are not the variants of unknown significance, and hopefully with Mullah's Dua, we can have genetic panels for many diseases in our community, including childhood and including cancer. So thank you, Dr. Mustafa.
So I just wanted to point out that Munira Ben said that's a really good point. She's giving a talk tomorrow on cancer genetics in Mumineen at 8 o'clock tomorrow. I highly encourage you to do that. And clearly there are opportunities. One of the things that is not, getting sequencing done is not the limiting factor. She's already identified potential solutions. The question is an interpretation and how we as a community will work together to use that to improve our children's health. This is the task.
Mustafa, one quick question.
Yeah.
So on the topic of mentorship that Bhai Sab raised, I know in Maryland we have, it is a struggle to get genetic counseling for patients. Can you put a plug out there for those of us who are considering career options to, about the value of genetic counseling and that as a viable career option?
Yes. So I'm going to make every genetic counselor incredibly busy. That is my plan. Yes, no, I think genetic counseling is extremely important. There are going to be, as the other guy was saying, that there are also going to be ethical issues and really important questions to answer. And so I think genetic counseling is really important as far as growth goes. And it will change very much from consent. Sorry, I got to finish. It'll change very much from consent to counseling, which is also a big change. Okay, 2 more questions, sorry. Anyone else?
My name
Yes.
is Umayma Jamaldin. I'm a OBGYN.
Uh-huh.
So my question is, if you have habitual abortion and, like two abortion miscarriages, where do we send the patient? Because we send the genetic testing for mother and father.
Yes.
Does that give us, it doesn't give us answer, or it does give a complete answer?
Yeah, so the question is, if you have 2 pregnancy losses, right, or abortions, what should you do? One of the things I've been working with OB is to actually collect abortus tissue. That's not trivial, right? Depending on you, sometimes it's lost. If it can be collected, because then you could sort of ask the question, not just what's potentially carrier in the family, but what is actually becoming homozygous. Again, one of the challenges is that we're still in a discovery phase. There are a lot of genes that are known, so it's worth testing. But there's also a lot of genes that are still not known, and so having the abortus tissue can really help, actually.
That is most difficult thing, because every time we send some specimens is not usable. So
It would be useful for genetic testing. It may not be usable for pathology. We should talk some more. Yeah.
Very quickly, if I wanted to give the offering in Houston for genomic testing for new families, what would the cost be today, and how much storage would they need to store the data?
So generally, the storage of the data is incorporated in the test. There are.
I would want to store it locally, like with the parents.
With the parents. So you want to download the data. It's it's not small. It's like 60 gigabytes. You could put it on your laptop.
So if you just stored like the portions that were unique, like the parts that
VCF, tiny, megabytes. So if you want just the variants, it's tiny. If you want the whole sequence data, that's a lot. So just the variants would be very.
What's the practical way to do it?
Definitely the variants. In fact, we've been arguing whether it's worth saving the raw data because DNA is actually a cheaper storage form.
Yeah.
And it's just easier to resequence patients than to actually store the data. But this is a whole nother argument. That may change with the growth of cloud computing, but this is another.